morning or good evening, depending on which part of the world are you. My name is Alaghband. I'm consultant ophthalmic surgeon based in the United Kingdom, and I'm the speaker for today's webinar. This session would be just over half an hour, and that would be followed by question and answer session for about 10 minutes. If you had any questions, any queries, please use either write them down or use the chat function during the Q&A session. I'm more than happy to go through them during that time. Invasive glaucoma studies, specifically iStent, Hydrus, and ECP. So let me just share my slides. So I've got some honorary and lecture fees from Glaucoma. So the topics I'm going to cover this afternoon or today is talk about the background, safety and effectiveness of minimally invasive glaucoma surgery, cost benefit analysis, quality of life, and then we'll bring you to the conclusion. Glaucoma affects more than 6 people worldwide, and million people over the age of 75 are in the UK, and this is the report for 2010. As the only modified factor is intraocular pressure, and the available options are lasers such as laser surgery, filtration, the new kid on the block, minimally invasive glaucoma. The term first coined by Ike Ahmed and Saeb Hadi back in 2012. It was meant to bridge the gap between medical and laser therapies, especially for mild to moderate glaucoma cases. There's a plethora of different devices available. The one which I'm going to concentrate on today are iStent, Hydrus, which are trabecular bypass, trabecular meshwork bypass devices, and I'm going to talk about ECP, which is endoscopic cyclophotocoagulation, in order to reduce the inflow. The paper I mentioned earlier by Ike Ahmed and Hadi Saeb, published in Current Opinion of Ophthalmology, they defined MIGS as ab-internal microincision procedures, minimal trauma, they are efficient, i.e. reducing the eye pressure and reducing the medication burden, and they have favorable safety profile. And finally, there would be a rapid recovery after these kind of procedures. The first one was iStent. The iteration looked like a snorkel. The second and third iteration became bullets. So the first paper, which looked at the theory of creating a device to create to bypass the trabecular meshwork, was published in 2005 by Smedley and Zhou, and they demonstrated that a single patent trabecular bypass at the level of trabecular meshwork, which we know that has the majority of resistance to the facility of outflow. That followed by another paper from the same group looking at the effect of iStent in cultured human anterior segment. They essentially showed that the iStent would effectively reduce intraocular pressure by around about quite significant number, around about 10 millimeter of mercury. And this is the first picture of the study with first generation of iStent. Then they looked at whether one iStent, how much IOP reduction we would get with one stent, then followed by second stent, then followed by third and fourth. And there was some cumulative effect from the second and fourth iStent implantation. However, the effect was less prominent compared to the initial one. And this is of iStent W inject in action. Trabecular meshwork. You fill up the eye. Sometimes you just nudge it a little bit in. There will be blood reflux, which is a very good sign. The advice is to implant at least 3 clots apart. And the idea is to hit the wider area of collecting channels. We know that the phaco alone in open-angle glaucoma can show around about 2 mm mercury. This is published in 2008. Then followed on to that, the first randomized clinical trial looking at iStent, published 11 by Tom Samuelson. So it was a prospective randomized controlled trial. They 240 mild open-angle glaucoma of 24 on medication, and demonstrate they looked at the proportion of subjects achieving IOP of less than 1 mm mercury after washout of the medication at 12 months. Demonstrated that the proportion of patients who had fake. There was a little caveat about this study. There was no postoperative medication washout in this study. What about the guidelines? What the available guidelines say? So European Glaucoma Society guideline mentioned that mix tends to have modest IOP reduction, as it was alluded through that study, which was around about 2 mm mercury, and the idea was to reduce the burden of medication. However, the guideline reiterates that the primary outcome measure, which is reducing the medication burden, is not in line with traditional glaucoma surgery, which is absolute IOP reduction. How about Cochrane review? When we look at the Cochrane review, it showed that there is not a lot of data available on long-term safety or cost effectiveness of mixed devices, and the methodology of the current studies are quite heterogeneous. And then when we look at the cumulative data available on this forest plot, can see although the number of drop-free cases is in favor of phaco iStent, the IOP reduction can overlap between the two groups. So it's not quite clear how much improvement you would get, but nonetheless, it's probably somewhere in the range of between 3 and 4 mm mercury, although in some other studies it's mentioned around about 8 mm mercury IOP reduction. But again, the argument would be there is a regression to mean from the very high unmedicated IOP to medicated IOP postoperatively. And then the other studies, again, there are, in terms of mean IOP lowering medication, still in favor of phaco iStent. So how about 1 iStent versus 2 iStent versus 3 iStents? Is it the more the merrier? So there was a study by LJ Katz and his group looking at this very question. They showed that they designed a 3-arm randomized controlled trial looking at short of 120 participants with open-angle glaucoma, and they treat them with 1, 2, or 3 iStents. And they showed that the amount of IOP reduction with the more iStent would be slightly higher, and it's in favor of 3 iStents rather than 1. So the more the merrier. Eventually, once iStent and the idea of MIGS took off, Hydrus came along, which was a larger device. It not only opens up the Schlemm's canal. There are some windows to allow the fluid to pass through, and also there is a little inlet to bypass the trabecular meshwork as well. So it's 3 birds with 1 stone, essentially. The first study was Horizon study in 2018. The same design, randomized controlled trial. At baseline, the IOP measurements in phaco Hydrus group versus phaco group were more or less similar. And they essentially showed that the IOP reduction was quite significant, and that was sustained throughout the study trial, the study duration for around about 3 years. This is a video of implantation of Hydrus. Again, the visualization of the angle is quite crucial. The device is bent at the tip with the introducer, so you need to impale the tip and then advance the device into the Schlemm's canal. It's quite satisfactory when it glides through the Schlemm's canal, as it happens here. And you can see the the shimmering of the device through the trabecular meshwork there. Then it came along COMPARE trial, which was meant to compare iStent versus Hydrus in phakic and pseudophakic eyes. So essentially, it was a standalone procedure in eyes, regardless of being phakic or pseudophakic, in mild to moderate open-angle glaucoma. And it showed that it's probably the Hydrus was more effective in terms of keeping patients drop-free. However, the estimate was meant to be a little bit imprecise. And also in COMPARE trial, they didn't provide any data on the medicated IOP at all. So essentially, the Hydrus showed that can reduce intraocular pressure a little bit more than 3 millimeter of mercury compared to iStent, but in reality, probably both of them are more or less about the same. Maybe 1 or 2 millimeter more IOP reduction by Hydrus would be achieved because of the different mechanism of action compared to iStent. In terms of safety, they were more or less comparable, and none of patients in Hydrus group required to have any further surgeries, whereas a couple of patients in iStent group required to have further surgery to mitigate for the glaucoma. So essentially, there's moderate. The Cochrane review mentions that there's a moderate certainty that Hydrus with cataract compared to cataract alone can increase the proportion of participants who do not require to have IOP reduction medication. And it can actually reduce IOP at short term and medium term. And again, if you look at the cumulative data on this forest plot, the data in terms of proportion of drop-free cases is in favor of phaco Hydrus as opposed to phaco alone. And similarly, at longer term, it would be still in favor of phaco with Hydrus. How about the intraocular pressure? Again, the data is in favor of phaco with Hydrus in terms of the IOP reduction at medium term. However, there is no data available on the rate of visual field progression, and none of the studies measured their health-related quality of life. There was another meta-analysis published in 2018 by Antonio Fia from Spain, looking at the available data up until 2018 on minimally invasive glaucoma surgery. So again, this is a busy forest plot on the here. oh, beg your pardon. Here, the phaco alone versus phaco iStent, again, in various studies, the results were varied, but overall, it was in favor of phaco combined with iStent. And then if you compared the one stent versus two stents, again, it was in favor of two stents rather. Again, another systematic overview or systematic review alluded that the proportion of participants which were drop-free iStent versus Hydrus were more or less similar. Mean change in IOP, again, more or less similar because it crosses 1, which was, and the confidence interval crosses 0, and mean change in IOP lowering medication per day was more or less about the same. So essentially, in a nutshell, Hydrus and iStent both are equally effective in reducing the eye pressure modestly, and they reduce the number of patients or proportion of patients who were drop-free as well. Again, EGS mentions that the mix tends to have a modest effect on IOP lowering effect. Roundabout, realistically, it reduces eye pressure in open-angle glaucoma cases by around about 2 millimeter mercury, probably in addition to the amount of IOP reduction from cataract surgery alone. So we covered the trabecular bypass devices. Now we are moving on another aspect of controlling the eye pressure, which is looking at reducing the inflow and endoscopic cyclophotocoagulation. The initial studies of endoscopic cyclophotocoagulation came from Urim in 1992. They looked at 10 people with blind eye due to neovascular glaucoma, and they showed that by performing endoscopic cyclophotocoagulation, they can actually improve the eye pressure satisfactorily. And this is a video of the procedure in action. So these white bits, white processes that are ciliary bodies, the red aiming beam is just aiming at the ciliary bodies, and the idea is to blanch, and the endpoint would be to go for shrinkage of ciliary bodies. And this laser treatment has to be applied for at least 270 degrees, ideally 360 degrees to be effective. So most often than not, it is performed in combination with endoscopic cataract surgery. One of the first randomized clinical trials was performed in primary angle closure glaucoma cases, which was a randomized control trial, and it was a pilot study. They showed that essentially phaco plus ECP had some additive effect in reducing eye pressure in cases of primary angle closure glaucoma. We already know that the cataract surgery is quite effective in reducing eye pressure in angle closure cases, and we can get some additional benefit from combining this cataract surgery with endoscopic cyclophotocoagulation. There are other studies, majority were retrospective studies so far, looking at small number of cases of refractory glaucoma, and they essentially showed that the IOP was satisfactorily reduced at short term, around about 1 year, medium term up to 2 years, and then further 3 years, IOP was reduced from about 80 millimeter mercury to 14 millimeter mercury and stayed at that level. And it was shown that to be quite safe, but obviously, like any other cyclodestructive procedures, you would expect intraocular inflammation and cystoid macular edema, which can occur, but it was in a small minority of cases in these studies. To date, there has not been any randomized controlled trials looking at the effect of endoscopic cyclophotocoagulation on primary open-angle glaucoma, and that was alluded into the recent Cochrane review. However, there is a new clinical trial comparing the effectiveness of phaco emulsification and then ECP versus phaco alone in the treatment of primary open-angle glaucoma cases with cataract, which is in short concept trial, which I am fortunate enough to be one of the principal investigators. Essentially, this is a multi-center prospective double-masked randomized controlled trial, which is conducted in the UK. The follow-up would be for 2 years from the day of surgery. The primary outcome measure would be mean postoperative washout IOP at 12 months and 24 months. And we are looking at early to moderate primary open-angle glaucoma cases with the presence of visually significant cataract. We are also going to look at the secondary outcome measures, such as the proportion of eyes with at least 20% IOP reduction at 1 year and 2 year, change in glaucoma medication, cost effectiveness, and the complication rates. And we will collect some additional data in terms of economic data and the use of glaucoma medication, as I mentioned earlier. At the moment, we are at the point of recruitment. So I have talked about trabecular bypass devices, and I have also talked about ECP. How about the cost effectiveness? As I mentioned earlier, there has not been many studies available. There are a couple of studies which I'm going to talk about here. One of them is this study from Canada, looking at the projected cost comparison between trabectome, iStent, ECP versus glaucoma medication alone in Ontario. So essentially, it appeared that apart from the medication group, ECP was the most cost-effective procedure, and iStent was the most expensive one of all. And then there was a more recent study looking at cost analysis of surgical intraocular pressure management in glaucoma cases. So essentially what they did, they looked at the cost of device, the cost of surgery, and then a mean reduction of IOP, and then they tried to work out how much does it cost to reduce 1 millimeter of mercury per device. Essentially, trabeculectomy and SLT were quite cost effective and quite cheap. Whereas iStent and Hydrus were quite expensive. How about quality of life? Again, there has not been an awful lot on this subject matter. There was a small from 2017 by Milena College, and the group looking at 88 eyes of glaucoma patients. 43 had trabectome, 20 iStent, 25 trabeculectomy. And they administered VFQ-25 to assess quality of life at 6 months post-operatively. And they did not show, they couldn't find any significant difference between trabeculectomy versus mixed group. But obviously, the sample size was quite small, and the follow-up time was quite short as well. The other thing was to look at the ocular surface disease changes as a result of having a trabecular microbypass and reducing the burden of the medication. There was a study published again in 2020 by Justin Schweitzer. It was a prospective study looking at 47 eyes with mild to moderate glaucoma who were taking 1 to 4 glaucoma medication and underwent cataract surgery combined with iStent. They looked at ocular surface disease index, tear breakup time, hyperemia, and conjunctival staining, and they assessed this at baseline and 3 months postoperatively. And they demonstrated that the ocular surface score improved and hyperemia improved, but they didn't administer any questionnaire in terms of the dry eyes to any patients. The clinical trials in the glaucoma surgery are based on World Glaucoma Association guidelines, which suggest the design and reporting of glaucoma surgical trials. And their recommendation is to have minimum of 3 years follow-up for any surgical procedures and implants, and define success rate based on absolute IOP reduction. This was looked at by very nice paper published by my Canadian colleagues David Matthew and Yvonne Bies in 2020, which was an annual review of vision, which was published in Annual Review of Vision Sciences. It was a critical appraisal of minimally invasive glaucoma surgery. So essentially, what they wanted to find out was the extent of adherence of minimally invasive glaucoma trials to the World Glaucoma Association guidelines for glaucoma surgical trials. They found 25 comparative mixed trials, and they found that the most common comparator was a cataract surgery, and the mean follow-up time was about 20 months, so it's short of 2 years. The IOP was measured by masked investigators in only 4 clinical studies, randomized 16% of clinical trials. Only 4 studies utilized at least 3 diurnal IOP readings. Washout baseline IOP measurements were used in 80% of randomized controlled trials, which is quite promising. And IOP-based survival care was provided in only 30% of clinical trials. In around about 65% of studies, at least one author had conflict of interest or some ties to the manufacturer of the device. And overall, there was poor adherence to the World Glaucoma Association guidelines. So just about half of them were compliant with those guidelines. So to conclude, Hydrus and iStent are new treatment modalities with moderate efficacy in IOP reduction, approximately 2 millimeter of mercury. Most of these mixed devices are safe, and they have created the ability to enhance the effect of cataract surgery at the time of the operation. There is a possibility that minimally invasive glaucoma surgery can improve ocular surface disease and reduce the medication burden. However, longer-term studies, cost-utility analysis, quality of life assessment, and better and more uniform clinical trials are required to be able to draw any conclusion on a long-term basis. That brings us to the end of my presentation. I am happy to take any questions.